Blood flows by without picking up oxygen. That's what makes it a shunt. Look at this. Blood flows by without picking up oxygen. Now, in this example here, we made this out to be because stuff was in there obstructing it. You know, crud, secretions. What else did I say was in there? Let me look. I just took my shoes off. You know, mucus plug. We said pneumonia atelectasis, like if it's totally collapsed, then air can't get in there. In a diffusion limitation, the problem in a diffusion limitation is something to do with this membrane. The alveolar capillary membrane, or the alveolar or the capillary membrane, something happens there. Maybe it gets fibrotic. Interstitial lung disease, ARDS, we'll talk about later, and severe emphysema. Those are examples of diffusion limitations. Now, in alveolar hypoventilation, the hypoxic failure is subsequent to the hypercapnic failure. We talked about that already. Things that can prevent the chest from moving will eventually also impact the ability to get oxygen to the blood. Now, in hypoxemic respiratory failure, there's usually a relationship, an interrelationship of mechanisms, a combination of two or more of the physiological mechanisms of, for example, a VQ mismatch or shunting or diffusion limitation or hypoventilation. It's usually a combination. So predisposing factors to respiratory failure. Well, certainly patients who have pre-existing lung disease, namely your COPDs, those patients would be at risk for developing respiratory failure because they're living on the edge. The more severe your COPD is, I kind of picture it almost like you're already over the cliff hanging on by a rope. But in the presence of pre-existing lung disease, anything that happens to the patient makes it that much worse. Not saying that some of these things in and of themselves won't produce respiratory failure if it's bad enough. But diseases and conditions that depress the respiratory drive or decrease chest wall excursion. Okay, depressed respiratory drive, what are we talking about there? Well, head injury like coma, a brainstem stroke, drug overdose, Guillain-Barré, spinal injury, Lou Gehrig's disease, abdominal surgery, thoracic surgery. I'm not going to want to take those deep breaths. Think about pain management, the effects of pain on chest wall excursion. Massive obesity. Honestly, I have taken care of a few patients that literally were trached and on a ventilator because they were too large to breathe. They had so much, there was so much of them. They were so heavy that they couldn't make, their chest wall couldn't move their diaphragm effectively. Now, this one, inability of gases to move from alveoli to circulation. The one that comes to mind is pulmonary edema, as in heart failure or fluid volume excess. You want to keep in mind that when you're dealing with water reasons, like pulmonary edema, remember CO2 is 20 times more diffusible in water than oxygen is. So in a water reason for respiratory failure, the patient might not have a hypercapnic problem. They just have a hypoxic problem. The CO2 is getting out fine. It moves through the water and moves on up out the airway, but the oxygen can't get in. Severe pneumonia will also get in the way of allowing oxygen to move across. Adult respiratory distress syndrome, we're coming to that. Your chemical or your smoke inhalations can damage the alveolar capillary membrane and make it very difficult for gases to move across. Okay, so really, respiratory failure in many ways can be wrapped up into these two situations. If the patient already has pre-existing lung disease, it's going to make it much more likely that either of these two is then going to aggravate their respiratory failure. The major threat of respiratory failure is the inability of the lungs to meet the oxygen demands of your tissues. That's why it matters. Respiratory failure can have a sudden or gradual onset. You get a sudden decrease in PaO2 or a rapid increase in PaCO2. That's a serious condition because the body doesn't have time to compensate for that, and that constitutes an acute respiratory failure. When your compensatory mechanisms fail, then respiratory failure will occur. Compensatory mechanisms, well, what are those? Cardiac output goes up, trying to move blood around some more. Respiratory rate goes up, trying to move air in and out more often. Heart rate goes up, trying to move the blood around. The signs of respiratory failure, they may be specific or they may be non-specific. So what's this look like? Well, the respiratory rate and pattern overall are going to reflect an increased effort. So when you look at the patient, they just don't look good. They look like they're working hard. First of all, we can talk about dyspnea. How many words can the patient say without pausing to breathe? A sentence, a phrase, a word. You may see dyspnea referred to as, three-word dyspnea. That means they say 3 words, then they stop to breathe, then they try to finish their sentence. Pursed-lipped breathing, you'll see an increase in pursed-lipped breathing. It's a body's natural compensatory mechanism to try to maintain open airways to allow the CO2 to escape. Our COPDers do it anyway, but they'll do more of it. They'll go. It helps reflect some pressure backwards. An increased inspiratory to expiratory ratio. Your normal I to E ratio is 1 to 2. So I take a breath in. It takes me twice as long to get it out. In respiratory failure, that ratio may extend to 1 to 3 or 1 to 4. What that tells you is there's airway obstruction. More time is needed to empty the lungs. Now, obviously, when people increase their IE ratios or they have pursed-lipped breathing, these are folks that have got underlying chronic conditions and now they're having an exacerbation. Respirations is normally a passive process. So when you see accessory muscles used, you see intercostal retractions, that's active, and that takes a lot of energy. Paradoxical breathing, this is not an early sign. This is a later sign of respiratory failure. And in paradoxical breathing, the abdomen and the chest, they move in opposite directions. They go out during exhalation and in during inhalation. And it results from maximum use of accessory muscles. Okay, this is not an early sign, and this is a real struggle. The tripod positioning, sitting up with the arms propped on an overhead table like this, helps decrease the work of breathing because when you prop up your arms like this, you increase your AP, that's anterior-posterior diameter of the chest, helps change some pressures in there. It helps facilitate the movement of air in and out. Pay particular attention to the idea that if a patient is slowing their respiratory rate without improving their respiratory parameters, that may indicate that respiratory arrest is imminent. All right, and respiratory arrest, it's always better to intubate someone who's still breathing than to have them stop breathing. Now you have an emergency.